Hi, my name is Kylie Scott,
And I'm Olivia Lambert.
and today's presentation for Psych 230 will be an assessment of different treatments for nicotine addiction.
So, nicotine addiction heightened in the mid 20th century when advertisers marked cigarettes and other tobacco products as being good for you, but the prevalence has decreased significantly since the 1964 Surgeon General report published a study linking tobacco use with heart and lung cancer. Prevalence is still pretty high today, and it is noted that 4.7 million middle and high school students use at least one tobacco product, which can be attributed to the rise of flavorful e-cigarettes in the 2010s, which specifically targeted adolescents. Every year, 500,000 die prematurely due to smoking or exposure to secondhand smoke, and the government spends about $170 billion a year just on medical care to treat smoking-related diseases such as cancer, emphysema, diabetes, COPD, and stroke. So nicotine is so addictive and extremely difficult to break, and it is unknown why for a long time. Since nicotine is not very pleasurable compared to other drugs, and cigarettes have an unpleasant smell and taste, but quitting nicotine results in a deficiency of dopamine release, causing the physical and mental symptoms of withdrawal. And it's also a stimulant, which makes focusing attention easier, which is a reason why people would want to keep doing it. However, most people who do smoke report the desire to quit either through reducing the number of cigarettes smoked or by taking a medication to reduce cravings. There are many different types of treatments currently approved by the FDA to treat nicotine addiction, such as nicotine replacement therapies, such as the gum and patch that deliver nicotine to the body without the harmful effects of tobacco, as well as pharmaceutical therapies such as bupropion and varenicline.
As Olivia mentioned, one such method of treating nicotine addiction are nicotine replacement therapies. The purpose of these therapies are to curb withdrawal symptoms, reduce motivation to consume tobacco, as well as help transition to completely quitting tobacco. And also, as Olivia mentioned, one of the primary things about these therapies is that they contain the nicotine without the harmful effects of the other chemicals present in tobacco or cigarettes. Nicotine replacement therapies rely on venous absorption of nicotine, and as you can see on the figure to the left, nicotine replacement therapies in general have a slower nicotine delivery in comparison to a puff of a cigarette, as well as a less potent nicotine delivery as a whole. Now, more clearly, you can see in the cigarette nicotine delivery on the left that plasma nicotine concentration spikes extremely high very quickly upon taking a puff, whereas for some of the other deliveries, they are lower. So for the gum, the plasma nicotine concentration is 10 in comparison to 15, and for the nasal spray, it's 7 in comparison to 15 in those first few minutes. The transdermal patch differs in an almost completely different way. It is extremely low until several hours later when the plasma nicotine concentration in the blood slowly increases. It is suggested that nicotine replacement therapies increase smoking cessation rates 2 times in comparison to non-pharmacological interventions. However, they are most effective in combination with psychological and behavioral support. There are several types of nicotine replacement therapies, namely nasal spray, lozenge, gum, inhaler, and patch. New research is coming out each year about different methods to stop smoking, and as well as tinkering with current treatments to control dosage amounts, timing of dosage release, and mess around with the different ways to introduce nicotine to the system. Nicotine replacement therapies mimic the effects of nicotine from smoking, with the goal of making smoking less rewarding to the body over time. The mechanism of action is principally nicotine binding to nicotinic acetylcholine receptors in the ventral tegmental area of the brain. Stimulation of these neurons results in dopamine release in the nucleus accumbens. So nicotine actually does 2 things in the body. Principally, it directly affects the release of dopamine. Interaction with nicotinic acetylcholine receptors that are on dopamine releasing neurons directly releases dopamine. But what some don't know, and is part of the reason why nicotine is so addictive and individuals experience such strong withdrawal effects, is that it indirectly affects modulation of dopamine. So interaction with nicotinic acetylcholine receptors on excitatory glutamate releasing neurons and inhibitory GABA releasing neurons control either the release or inhibition of dopamine in the body. And some of the biggest points where nicotine replacement therapies differ from cigarettes in introducing nicotine to the body as mentioned earlier, is the harmful chemicals being missing from nicotine replacement therapies. However, another important point is that nicotine release is more controlled in nicotine replacement therapies. For example, in the figure a few slides ago, we saw the slow sustained release of nicotine in the patch, as well as acute microdosing in the gum, spray, or inhaler. And withdrawal symptoms cannot be completely eliminated, unfortunately, with nicotine replacement therapies, since nicotine replacement therapies can't replace that quick, strong high that is able to be delivered by cigarettes. And this is also reinforced by the data from the graph. Advances in nicotine dependence therapies has led to the development of nicotine-free treatments, as Olivia will explain in the next few slides.
So many pharmaceutical therapies have been approved by the FDA to treat nicotine dependence, one of which is bupropion, more well known by its branding of Wellbutrin. It was originally used as an antidepressant, but was approved to treat nicotine dependence in 1998. The method of action is that it blocks dopamine and norepinephrine reuptake pumps in the mesolimbic dopaminergic system, which is the pathway connecting the VTA in the midbrain to the ventral striatum of the basal ganglia in the forebrain. And this is the area of the brain responsible for producing and mediating reward for nicotine and other drugs. And this method makes it more likely that dopamine and norepinephrine bind to their respective receptors. This results in the effects of nicotine, the pleasurable effects of nicotine on the body, without actually needing tobacco to do so. And this may stimulate the actions of nicotine on brain reward systems and the reward achieved by tobacco without actually having to use tobacco. And this is also considered a nicotinic receptor antagonist in that it may block some of the positive reinforcing effects of nicotine if it is delivered via tobacco products, thus making it less likely that users will want to smoke tobacco. So there have been many studies testing the efficacy of bupropion in treating nicotine dependence, and a meta-analysis of 4 different clinical trials showcases the success of bupropion in smoking cessation and preventing relapse. And it shows that odds ratio for abstinence is 2.54 at 6 or 12 months after treatment, meaning that bupropion is more effective than a placebo for smoking cessation. And it also exhibits the dose response effect, meaning that it is more effective when taken at higher doses during the treatment phase, though this effect wanes after discontinuing therapy. The meta-analysis also showcased predictors of successful smoking cessation, such as a lower initial smoking rate to begin with, longer periods of previous abstinence attempts being male, and the bupropion dosage as seen in the dose response effect. And bupropion is also significantly more effective than the patch, but they are more effective when used together compared to a placebo, which is something that users may want to consider. And this table showcases and summarizes the results of that meta-analysis. And a p-value of less than 0.05 means that results are statistically significant, meaning that in all of these instances, bupropion is more effective in creating continuous abstinence compared to a placebo. It is also effective in special populations, such as those with COPD and those who had a high relapse rate in previous quit attempts. And then the next drug is varenicline, known as its brand name of Chantix. It's a partial agonist of alpha-4 beta-2 nicotinic acetylcholine receptors. It blocks the ability of nicotine to activate these receptors and thus stimulate the central nervous mesolimbic dopamine system. It's designed to partially activate this system at a significantly lower level than nicotine, while blocking nicotine from binding to its receptors to wean people off of dependency to the drug. It also binds with moderate affinity at serotonin receptors, explaining why some who take this product may experience nausea as a side effect and may not want to take it. So the efficacy of varenicline in treating nicotine dependence has also been tested, one of which was a randomized placebo-controlled clinical trial providing the drug for 6 months to evaluate a reduced to quit approach. And this approach is used in participants who aren't quite yet ready for an immediate quit, but are willing to try by reducing the amount of tobacco smoked. Participants either received varenicline or a placebo for 24 weeks while monitoring tobacco use from self-reports and carbon monoxide measurements. And in the end, the varenicline group had significantly higher continuous abstinence rates than the placebo group. And this trend even continued after treatment when participants weren't using the drug anymore. Even though enrolled participants initially reported not being ready to quit, so expected abstinence rates were low, varenicline still helped a ton in achieving abstinence. And the main concern is the potential for adverse side effects, such as constipation and weight gain. These have been refuted as as these are established effects of smoking cessation in general without taking drugs. And in contrary to popular belief, varenicline also did not increase the risk of suicidal ideation or psychiatric episodes. Although these drugs are clinically effective in reducing the tobacco dependence, they result in low quit and high relapse rates when implemented in the real world. This is likely because nicotine dependence and cessation is not just affected by what is happening neurologically, but it's also impacted by psychosocial factors such as willpower, and as well as the negative side effects of all of these treatments. So there is a need for better treatments, and many clinical studies in the past 2 decades have researched the possibilities. Although they are not currently approved by the FDA, scientists are working on it. One of these is N-acetylcysteine, or NAC. It's a widely available nutraceutical supplement with antioxidant properties. It's effective in relapse prevention, reduction in the number of cigarettes smoked, and improvement in the harm to the lungs caused by tobacco exposure. It's advantageous over other therapy options because it's inexpensive, safe, tolerable, and manages comorbid psychiatric symptoms. And another possibility is a nicotine vaccine, which is favorable to a lot of people because it's a one and done deal and you don't have to keep taking drugs for a long period of time. It utilizes immunopharmacotherapy, which involves the induction of nicotine-specific antibodies that bind to nicotine in the blood. And this complex is too big to cross the blood-brain barrier, so it doesn't enter the brain and reduces nicotine's pleasurable effects on the smoker. And one candidate is a peptide-free synthetic vaccine with alpha-galactosylceramide as an adjuvant, which was created in 2019, but has yet to be approved by the FDA. And the reason it has yet to be approved is because clinical trials have been successful in animals, but clinical trials in humans have largely failed to show that vaccine inoculation increases abstinence rates. So in conclusion, there have been lots of successful implementations for reducing nicotine cessation, but there is still a lot of work that has to be done.